Hello, my name is Truong, and I'm a fourth-year diagnostic radiology resident. I'm here to present my research on multiparametric MRI correlation of clear cell renal cell carcinoma histological grade. Here's a brief outline of my presentation today. I would like to begin by presenting a brief background on renal cell carcinoma, which represents greater than 90% of kidney malignancies. Of these, the clear cell subtype represents 70%, with the remainder represented by papillary and chromophobe subtypes. The clear cell demonstrates the most aggressive behavior, with prognosis defined by 5-year survival rates, which are inversely related to the histological grade at time of diagnosis. Traditionally, biopsy has been the gold standard for definitive diagnosis and grading, but may involve procedural complications, sampling errors, and subjective grading variability. Furthermore, upon discovery, many solid lesions do not undergo pre-treatment biopsy and are instead surgically resected. The histological grading systems encountered in my research are the Furman and the WHO International Society of Urological Pathology Systems, with grades 1 and 2 designated as low grade and grades 3 and 4 being high grade. The grading determines the management received by the patient, with low grades suitable for conservative management and high grade undergoing radical nephrectomy. Limitations of the Furman system included poor inter-observer reproducibility and questionable prognostic significance. Therefore, in 2016, the Furman grading system was replaced by the WHO ISUP system to address these limitations. Presently, multiple imaging modalities are available for the investigation of clear cell RCC, some of which are listed here. In particular, multi-phase contrast-enhanced CT and MRI have been used to identify and classify solid renal lesions, including RCC. In my presentation, I will be addressing multiparametric MRI. Briefly, the objective of my work was to investigate the suitability of multiparametric MRI as a non-invasive grading tool for clear cell RCC. This was a retrospective study between 2011 and 2015 and 2018 and the current. The PACS was queried for clear cell with exclusion criteria as listed as below. These were the MRI parameters being evaluated within the study. After applying the exclusion criteria, our study was limited to 66 patients. Statistical analysis involving 13 independent variables was performed to evaluate their relationship to the histopathological grade. Additional information regarding our methods and selection. This table summarizes the data set in this study. Essentially, most clear cell RCCs, regardless of grade, demonstrated arterial enhancement and increased T2 signal relative to background renal parenchyma. Based on our statistical analysis, the following MRI parameters highlighted in yellow predicted a difference between histological grade. In particular, ADC values, arterial enhancement, a degree of enhancement greater than renal parenchyma, T2 signal, intensity, heterogeneity, and fluid component, as well as hemorrhage, biopsy size, and tumor thrombus were differentiators within our study population. Below are images showing high-grade clear cell RCC. As you can see, there's large tumor size, T2 heterogeneity on the coronal and axial T2 images. On the pre-T1 image, you can see increased T1 signal suggestive of hemorrhage. On post-contrast image, you can see the avid arterial enhancement. Tumor thrombosis also seen, and the last two images denoted F and G demonstrate restricted diffusion with decreased ADC signal. A different patient also with high histological grade demonstrating similar imaging features. These MRI features are absent in a patient with low histological grade. My findings are concordant with a study from 2017 by Villavicencio. The limitations of my study are as follows. These are references, and thank you for your time.